Replicase Hip Cement Spacer Mold. The name Replicase combines the meaning of the two words replicate and case. Replicase consists of a case to replicate antibiotic-loaded cement spacers for the use in patients undergoing a two-stage revision surgery. Over the last decade, the rate of paraprosthetic joint infection is about 1% in primary THR. As to the revision surgery, the infection rate is between 2 and 6%. The risk for paraprosthetic joint infection is estimated to be low. However, considering the increasing number of joint replacements, the increasing number of patients with multiple comorbidities, and the lifelong risk for acquiring hematogenous infection, the total number of PJI will further increase. Clinically, treatment options of postoperative infection include oral or IV antibiotics, debridement with prosthesis retention, and one-stage or two-stage reimplantation. The first two methods are limited to a small subset of patients, and the outcome is unstable. Therefore, staged exchange arthroplasty is considered as an effective and reliable treatment while facing postoperative infection. One-stage reimplantation, so-called direct exchange arthroplasty, proceeds reimplantation of the hip prosthesis at the time of the initial debridement. The prosthesis is revised to a cemented implant that can be fixed with the antibiotic-impregnated cement. The infecting organisms can then be managed by appropriate antibiotics. However, compromised results were seen in patients with polymicrobial infection and immune-comprised condition. In the interval between septic THA resection and the eventual reimplantation of another prosthesis, local antibiotics can be delivered with a cement spacer. After the removal of microorganism, cemented or cementless implant can be applied to the patients. Literatures demonstrate better results of more than 90% infection control rate and less recurrent infection incidence over other treatments. This procedure is currently considered the gold standard for its capability of providing antibiotics delivery, proper soft tissue tension, limb length, and better patient comfort between stages. There are two types of antibiotic-loaded cement spacers that are typically used in two-stage revisions of total hip arthroplasties: static and mobile spacers. Static, so-called non-articulating spacers, allow local delivery of a high concentration of antibiotics and at the same time function to maintain joint space for future revision procedures. The disadvantage of a static spacer is that it does not allow physiological motion of the joint and results in periarticular scarring and muscle contractures and substantial impairment of patients' normal daily activities during the prolonged course of treatment. Another drawback of the static spacer is bone loss attributed to migration of the block spacer. In contrast, articulating spacers permit more joint motion and can improve function prior to the second-stage reimplantation. The improved joint function and decreased scar formation after resection arthroplasty can facilitate exposure during reimplantation. The use of a mobile spacer restores soft tissue tension and allows a greater degree of joint motion, which has been reported to have a better outcome than the use of a static spacer. However, the limitations of the mobile spacer include the risk of spacer fractures and hip dislocation. Traditionally, surgeons make a mobile spacer manually in the operation room. These handmade spacers show a higher rate of spacer fracture and dislocation due to the mechanical complications. Spacer fractures and dislocations, as well as femoral fractures, may endanger the functional outcome and impede the later prosthesis reimplantation. From the literature, the complication rate of the handmade spacers is as high as 20 to 50%. To prevent dislocations between stages, the use of a spacer cup is suggested in the literatures, especially for the patient with acetabular bone defects. The spacer cup should be implanted in these unstable cases, and this could decrease the risk of femoral spacer dislocation and prevent spacer migration into the pelvis. Additionally, the cement-on-cement bearing prevents the damage of bone and avoids acetabular erosion. Now, Replicase makes the two-stage revisions much safer and easier. Replicase Hip Cement Spacer Mold is an instrument set to reproduce cement spacer for post-operative infection cases. The biomechanics-friendly design benefits the joint function and facilitates the reimplantation surgery. As a total hip solution, Spacer Case is designed for the femoral spacer, and the metal cup mold is applied to shape the acetabular spacer cup. Replicase is made with autoclavable material so that it can reproduce cement spacer cost efficiently. There are 3 sizes of Replicase hip cement mold: small, medium, and large. The dimensions of the spacer cup are 46, 49, and 52 millimeters respectively, and the corresponding femoral heads are 42, 45, and 48 millimeters. The shaft neck angle is designed as 130 degrees, and the stem length is 145 millimeters. The stem distal diameters are 9, 10, and 11 millimeters, corresponding to small, medium, and large sizes. As a total hip design, the cement-on-cement articulating serves the wear-bearing interfaces. In order to protect the cement surface and reduce the wear during range of motion, additional 2 millimeter clearance is set in each side. This also eases the reduction procedure during operation. The material of Replicase Hip Cement Spacer Mold is medical-grade silicone, which can be sterilized by autoclave and is resistant to mild acids and alkalines. Thus, it tolerates the standard cleaning and sterilizing procedures. Besides, the biocompatibility of medical silicone is high. Replicase is a non-allergic, safe, and reusable instrument for reproducing antibiotics-loaded cement spacers. Let's see how Replicase works. The first step is to determine the acetabular size by measuring the cup retrieval or the acetabular bone. If the acetabular size is equal or larger than 50 millimeters, total hip cement spacer is recommended to lower the risk of dislocation. If the acetabular size is less than 50 millimeters, hemiarthroplasty is suggested due to the limited space of cement mantle. When total hip spacer is chosen, at least a 2 millimeter cement mantle on each side is required. For example, a small-sized cup mold is chosen for the 50 millimeter acetabulum. Then a spacer cup with 50 millimeter outer diameter and 46 millimeter inner diameter will further be shaped. For the femoral part, an S-sized spacer case is utilized to make a corresponding femoral cement spacer. To prepare the femoral spacer, 80 to 100 gram bone cement is needed. Generally, small and medium-sized spacers need 2 packs of bone cement, and large spacers require 3 packs. Fill the silicone mold when the bone cement is in the doughy stage. Then, close the mold and wait until the bone cement is fully polymerized. After the femoral spacer, the acetabular spacer cup is prepared with additional bone cement. The amount of bone cement required depends on the size of the patient's acetabulum and the degree of bone defect. When the bone cement is in the doughy stage, finger tap the cement into the acetabulum and shape the cup with the metal cup mold until the cement is fully polymerized. To maintain an adequate mechanical property, Replicase Hip Cement Mold strengthens the neck dimension. If the mechanical property is still a concern, surgeons could select an appropriate metal device as support and reinforce the mechanical strength of the cement spacer. With Replicase Hip Cement Spacer Mold, surgeons are able to replicate a biomechanical shaped, custom-fit, total hip cement spacer with ease. Thank you for watching.